I think today we have a good standard in biomechanical fixation of the rotator cuff, tendon to the bone, but the critical point is what happened with the healing. The healing response, bone to tendon, is not really clearly defined, and we have to work on that. I think with growth factors, enhancement of the healing, this will be the really step we need in the next 5-10 years. And all over the world they are working on that. We have a big lab working in this field, and I think this will be the biggest step we need in the next 5 years. The third ankle is still at 3 o'clock. Den vierten haben wir. We would like to invite you to this 15 international course on shoulder arthroscopy and shoulder surgery. This course has a long tradition. We started this 15 years ago. We wanted to help patients by teaching the surgeons and the residents how to improve their skills, their knowledge, really to help the patients. So this course has several parts. It's an anatomic workshop where we try to work on cadavers to improve the techniques, to see new materials, new implants, new techniques. Then we have a lot of presentations by our international faculty from all around the world. They will show us what can we do, how can we be better. And there are also a lot of small workshops with the industry. They show us new materials, new implants, new technique. So all around, I would really like to invite you to this wonderful experience in shoulder arthroscopy and surgery of the shoulder to improve our knowledge for the patients. Da ist der Pectoralis minor darüber. So weit kann man, dann kann man ein bisschen weiter gehen. Ich spüre wieder. Man sieht das Wasser schon über das Tuberculominus. Daran denken, dass der Subscapularis
Wir schalten jetzt direkt in den OP, von wo aus Professor Imhoff auch nochmal begrüßen wird, und wir haben uns das so vorgestellt, dass Sie alle Fragen, die Ihnen während dieser OP kommen, direkt an mich adressieren.
Also so ein bisschen debretieren, glaube ich, das ist adäquat. Zusätzliche Läsionen, dann haben wir 25% zusätzlich Hose arbeiten, noch medial arbeiten. Genau. Also da kann man ein bisschen deprimieren.
My name's Augustus Daniel Mazzaka. I'm an Associate Professor of Orthopedic Surgery at the University of Connecticut, the New England Musculoskeletal Institute. My specialty is shoulder and elbow surgery. At the University of Connecticut, I teach medical students, residents, and fellows. We have a research lab that involves both the biological, the biomechanics, and the outcomes of various shoulder and elbow procedures that we do. We have a bioskills lab there that I run, and further we have clinical education both in the OR and in the clinic. In 5 years, the greatest achievement in rotator cuff surgery, I believe, will be biological augmentation. Up to this point, I think industry has done an exceptional job of making anchors strong and able to stay in a soft bone, augmenting and improving suture, and the instruments that we're able to do either open or arthroscopic to repair the rotator cuff tendon to the bone. The problem is, in many of those surgeries, the rotator cuff tendon still pulls away from that fixation. And that reason for that is not because of the mechanics of it or poor surgery, it's because of biological failure. The body tries to heal itself, but sometimes comes up short. We think this is to do with either blood supply or the lack of other cofactors, and that'll be the biggest improvement. We are working with, as well as many people from around the world, on stem cell augmentation, mesenchymal stem cells, and the use of their ability to try to improve tendon healing to bone, various cofactors, growth factors, different types of instruments and applications that'll help the body heal itself. Thank you.
For me personally, I hope that in 5 years from now we will have wireless instruments like a wireless or cableless arthroscope or shaver. That would be a great advantage for us as surgeons.
And I believe that we are living now in a very exciting period. We are very much open to those biological means, and I think this will be the most important step, that we can have really also a biological healing, especially for elderly people and for revision surgery.
And the third big point is the arthroplasty. All-around arthroplasty is about modularity of the instruments we have and about having more and more cases, and so having more and more revision cases.
And I think now it is important to have the goals for the patient. The patient must know what he has and what we can do and we can offer him. Even the genetics, things like Carr told us that it is very important that we cannot help all the people. And I think that's one of the, we must learn what are the limitations. And I think sometimes we do too much for the patients and we don't listen to the patient.
I think it's a very difficult question to answer, but I assume that in 5 years from now we look more on the perfusion, on what we do to the arteries after we repaired the rotator cuff. It's not so much about mechanical stability.
Wir befinden uns in einer Phase, wo jetzt die Arthroskopie eigentlich etwas die Oberhand gewonnen hat, sodass wir einen großen Teil der früheren offenen Schulteroperationen heute arthroskopisch durchführen können, sodass wir in den nächsten 5 Jahren zum Beispiel wahrscheinlich dann alle Rotatormanschetten, das ist ein häufiger Eingriff in der Operation, arthroskopisch durchführen werden.
During reconstruction we will be able to have some biological injections or some grafts to reconstruct, to put on the reconstruction during our operation.
In Europe we probably have one major thing, that's the costs. We are doing surgeries with a lot of technology which is expensive. Implants are expensive, and I think healthcare and technology, this will be an interesting issue, how to solve that the costs are not going too high and we can keep the costs under control.
A lot of it has to do with the healing. I think the techniques that we now have available have evolved, and we just need to make them a little bit more uniform, not just amongst those who practice shoulder, but those who also have a general practice and do shoulder surgery in addition. Thank you very much, and it's been a pleasure to be here.
Jeweils zwei Wiederkämpfe setzen. Und dann kann man diesen Faden hier rüberziehen und diesen Faden da. Sodass man eigentlich auf der Seite
die eingeklappt bekommen muss, ist noch nicht dabei. Like very wet.
That's okay.
Ja.
Das kommt dann natürlich dazu. Ja, wenn es dann vernarbt ist, auch dann, ich meine, man sieht es ja hier jetzt auch so ein bisschen, ja, das, eigentlich muss das da so eine Gleitschicht haben.
Strukturversagen im klassischen Sport beziehungsweise einen Trainingsprozess mit einbeziehen. Hier sehen Sie eine Übung, die
Normale zum Beispiel im Subscapularis vorbeiläuft und dass da unser Körper ist ja nicht lange Zeit da. Das ist aber tatsächlich auch
eigentlich tut man es nicht mehr, denn man weiß, dass es so ist. Schlussvorgang, einander nicht so sehr. Ja? Und das war gut, auf der Bank und dann haben wir das Sicherheitsgurt ja, etwas nah an der
ganz viel Wert zu legen.
I hope you enjoyed this presentation about our international shoulder course, and I really would appreciate if you could come next year to our next shoulder course here in Munich. Nicest weather during the Oktoberfest. It will be wonderful. We will have you here as a guest. Thank you for coming and joining us.